All right, I think we'll go ahead and get started. Good afternoon, everyone, and welcome to the webinar Leading During a Public Health Crisis, Part 3, Measuring Burnout. My name is Molly Mindbress, Associate Director of NHSC Educational Programs at the Association of Clinicians for the Underserved, and I'll be your moderator for today. This webinar is brought to you by the National Health Service Corps, Empowering Clinicians for Resiliency and Transformative Care Initiative, a project of the Health Resources and Services Administration, also known as HRSA to most of you. Diane Fabi King, who is the Senior Public Health Advisor in the Division of National Health Service Corps from HRSA, typically provides our introductions. She's unable to do that for us today, but she wants you to know that she is here, she's listening in solidarity, and we're so glad you're here with us today, Diane. We're excited to continue talking to you all about the ways that you can foster organizational resilience and support clinician well-being. This HRSA initiative was designed to help NHSC participants and new clinicians in the field prepare for the rewarding and challenging experience of serving in health professional shortage areas. We're so grateful for those of you who've been able to attend our webinars and take advantage of our resources. As part of this initiative, we've also designed some of our webinar series and resources for leadership and administrative staff at NHSC approved sites. You all are uniquely positioned to positively influence the culture, work environment, and organizational policies and practices that can lead to improved clinician wellness. We really want our NHSC participants to feel supported so that they're doing well while they're practicing in the field as part of the National Service Corps, and so that they stay at your organizations after they're done with their terms. So we're all really glad you're here today, joining our webinars and learning more about how to support your National Health Service Corps clinicians. And I see Diane has joined us. Hey, Diane. We can't do this important work without all of you. We are going to open up a Slido, a poll on the right side of your screen, just to get a feel for who's in the room. If we have National Health Service Corps participants, NHSC approved site staff, HR, C-suite leadership. So if you have a moment, just click on that poll and let us know your role related to the NHSC. For those of you who may have missed webinar series 1, Clinician Wellbeing and Self-Care, you can find webinar recordings and related materials on our archived resources page, which we'll post in the chat now. Webinar recordings from previous webinars in our current webinar series 2, Fostering Resilience at the Organizational Level, can be found on our webinar registration page, which we'll also post in the chat now. We have a couple more webinars in this mini series on after this mini series on fostering social support for clinicians, and we'll also have a grand rounds from medical director of clinician wellness at a health center in Rhode Island, talking about all the great work that they're doing. Webinar series 3 will begin in August and will focus on health inequities and social determinants of health. So please look out for information about that next series and join us if you can. So on to today's presentation. We're really excited to have Dr. Nigel Girgrah for today's session to share his experiences and expertise with you all in measuring clinician burnout. Nigel currently serves as the Chief Wellness Officer at Ochsner Health in New Orleans, Louisiana. He leads the efforts of the Office of Professional Wellbeing at Ochsner Health, which is charged with improving the professional fulfillment of their employed physicians and advanced practice providers, focusing on enhanced practice efficiency and personal and team resilience, and building an organizational culture that promotes provider well-being. Nigel received both his medical degree and Ph.D. from the University of Toronto. He has specialist certification in both gastroenterology and internal medicine with the Royal College of Physicians and Surgeons of Canada. He's a practicing transplant hepatologist and also serves as the medical director of liver transplantation at Ochsner Health. Today's webinar is the third and final in our mini-series on leading during a public health crisis. In the first 2 webinars, we discussed the core competencies leadership staff need to prepare for and navigate public health emergencies, as well as approaches supporting clinician mental health. Today, Nigel will talk to us about the importance of measuring burnout among your clinicians and things you should consider as you're choosing an assessment tool, how to implement those tools, and what you can do with results to enact organizational change and reduce clinician burnout. In our first webinar series, we provided an infographic highlighting some commonly used and evidence-based burnout assessment tools. Since it might be useful for you to look at that infographic while Nigel's presenting, we'll post a link to that infographic now in the chat. And real quick, before I hand the mic to Nigel to get us started, I'd like to go over a few housekeeping items. This webinar is being recorded, and a link to the recording will be emailed to you within 2 days. The PowerPoint slides can be found on the webinar registration page, which we'll link to again in the chat. Related documents and previously recorded webinars in the mini-series are all available on the webinar registration page, as I mentioned before. This is a 1-hour webinar. We'll have time for Q&A at the end of the presentation, so please type questions you have for Nigel in the chat box on the right side of your screen. You may have to manually open that chat box by clicking on the chat icon in the bottom right corner of your screen. There will be opportunities to engage with Nigel and other participants during the presentation through polling, the chat box, and by raising your hand to speak. If you do have a technical question, please contact our colleague Josh. His contact info is pasted in the chat. Finally, we'd also appreciate your feedback on today's session. Please complete our survey at the end of the webinar to let us know how we did and how we can improve our trainings. To see closed captions, click on the CC icon in the bottom left corner of the webinar window. And I'll hand the mic over to you now, Nigel, and you can begin our presentation.
Great, thank you, Molly. I appreciate the introduction, and it's exciting to be able to join you all in your, wherever you are in your organizational journey towards workforce well-being. As Molly mentioned, I'm a practicing transplant hepatologist. I've had a number of traditional operational leadership roles at Ochsner, and then for the past 4 years, I've had this less traditional executive leadership role, Chief Wellness Officer. So I embarked on our organizational journey back in 2018, and it became evident that part of developing any strategy or a strategy around our workforce well-being has to be measuring well-being and burnout. And I sort of look at the sort of healthcare workforce well-being story, kind of where quality and safety was 20 years ago. For some, it still remains this kind of big, fuzzy, nebulous subject. And so I think it is important to remove as much fuzziness with some of these instruments and that we'll discuss. So if I can just advance the slide. So here are our learning objectives for today. So there are, as you will learn, many burnout assessment tools out there. So we'll talk about how to select a tool or an instrument that's best for your own organization and what you're emphasizing at your organization. To that end, we'll go through some of the different assessment tools that currently exist. And then finally, we'll discuss some strategies around for implementing an assessment tool once you agree on one. So I guess maybe a couple of questions to open things up, and I think there will be, for a couple of these, a survey Slido tool. So first question, how does your organization measure clinician well-being and burnout?
I'll just chime in here too, Nigel, to say if you're not able to open the Slido poll on your right side of the screen, some of the options we have listed are surveys, staff meetings, one-on-one supervision meetings, department meetings, focus groups, other, or maybe you're not measuring at all. So feel free to post in the chat if you cannot see those. And Nigel, let me know if you want me to read out the results that we're getting.
Yeah, have the results been posted, Molly?
So to see the results, folks will have to enter an answer, but I can let you know right now, 50% of respondents are saying they're using one-on-one supervision meetings. Oh, the numbers are changing as more people are answering. It looks like about 17% measure burnout through staff meetings, 8% through surveys. So one-on-one supervision meetings has gone down to about 38% now. About 8% use department meetings. I don't think anyone has responded that they use focus groups, and 31% are saying others. So maybe we can folks can post in the chat other ways that they're doing that.
Okay. Thanks for reading those out, Molly. I did answer, and I'm not seeing the answers, but that's fantastic that you were able to summarize that. Well, maybe move on to the second question. So if you're using currently a survey or a tool, which one do you use?
So right now I'm seeing 100% are saying other, and that might be that they are not using any, or they're using one that's not listed. So again, if you're if you entered other in the Slido, could you post in the chat what you're using, or maybe just if you're not using any, that was your response.
So any answers, Molly, to that question?
It looks like they're all other, Nigel, which
Okay. Well, I guess that suggests that today's session will be helpful then. So, and then maybe in the chat, if I know many of you aren't using surveys or tools, but if you have any thoughts about how your organization tries to affect change in terms of enhancing clinician well-being or workforce well-being, please post that in the chat. Okay, thanks, Megan. So I will say that qualitative data from department meetings and focus groups is as important, if not more important, than quantitative data, which we'll be discussing today, at least in my opinion. So I guess I'll move on. So, I mentioned there are different well-being dimensions, and different tools emphasize to different degrees these different dimensions. So you sort of have to think about and engage your colleagues in terms of what dimensions matter most to you and your organization. You also have to take into consideration the burden of the survey. So there is a burden to the individuals who take the survey in terms of time. And we know for certainly physicians, the most precious currency is time. And then there is a burden to the organization, potentially in terms of cost or complex statistical interpretation. You also have to ask yourself, how actionable is the data? I found that the only thing worse than asking folks about burnout is asking but not doing anything about it. So you have to take into consideration how actionable the data is. If you are going to implement changes, you have to then think about, is the survey, if you're going to use it in an iterative fashion, sensitive to figuring out whether it's been successful in terms of the interventions and impacting any change to burnout or workforce well-being. Obviously, the results, you want to make sure they're valid. And then you also have to ask yourself, who is the audience, the applicability? And I know this has changed at our organization. When I first started, our scope was just our employed physicians and APPs. That was pre-pandemic. And now the scope of the Office of Professional Wellbeing is all members of the Ochsner workforce. So that's an important question to ask when you're picking an instrument to use. So as I mentioned, there are a number of different dimensions that you may be interested in assessing. Burnout is one of those dimensions, but there are other dimensions to consider: professional fulfillment, engagement, quality of life, emotional health. So those are things that you'll want to ask what's important to you and what's important to your organization. And then before you pick a survey, you're going to want to ideally engage stakeholders. So who are the decision makers in your organization? The chairs of departments, the chief quality officer, the chief medical officer. We have a chief experience officer at Ochsner, and certainly they're going to have some perspectives in terms of what dimensions they want to look at as you're surveying folks. And I'll be interested, and you can post this in the chat. When you look at your organization, who do you think would be individuals that you'd want to engage before selecting a tool to use to assess burnout? And you can just post that in the chat. Okay, I think I saw clinicians. That's important.
And if folks can't see the chat, just a reminder that there's a little chat icon in the bottom right corner, and just click on that to open up the chat and put in some responses.
And Molly, if there's anything I find in my chat, it's going back to the beginning. I've seen, okay, clinicians. So yeah, clearly our clinician stakeholders are going to be important, but I think, or my bias would be, in order to be successful, it will be important to bring on not just your clinicians, but folks in your C-suite, just to increase the likelihood that there'll be buy-in and success as you go down the journey.
We did get some more responses, Nigel.
Okay.
Folks are saying CMO, CEO, director of nursing, management and directors.
Great. Behavioralists, exec team. Yeah. As many, obviously you probably want to be decisive, but to the extent that you can, ask people and get their opinions, I think that's going to increase the likelihood that you're going to succeed. So I'll move on to the next slide. So these are some of the instruments that are available. There are some other ones that are available that are not mentioned here. Some of these are predominantly unidimensional, meaning they just primarily look at burnout. I would argue the Maslach burnout inventory is multidimensional, but I imagine its main focus is burnout. So the MBI, the one directed for medical personnel, is probably the most well-known. I know before I took on this role, this was the first survey that we implemented at Ochsner back in 2017. It has 3 domains that it's looking at. One domain is emotional exhaustion. Secondly, cynicism or depersonalization, and then personal accomplishment. Another survey that exists is the Oldenburg Burnout Inventory, which primarily looks at 2 domains, exhaustion and disengagement from work. The Copenhagen Burnout Inventory has 3 domains, looking at well-being personally, work-related well-being, and then client-related related burnout. And I guess in the healthcare setting, this would be burnout related to taking care of patients. We at Ochsner, since 2017, have used the Mini-Z survey. We've used that 5 times year over year. It principally has 2 domains, 5 questions around is the work environment supportive, and then 5 questions really around not just EMR stress, but workflow. It also includes a single item assessment for burnout. And then there are tools that are bidimensional or multidimensional. The Stanford Professional Fulfillment Index looks at both burnout and professional fulfillment. So again, things to consider. I mentioned, the most precious currency for our clinicians is time. So you want to be mindful about how long it takes to complete the survey. Does it take 3 minutes? Does it take 30 minutes? And if you want a robust response rate, obviously you want to minimize the survey burden, the survey fatigue to those that you are who you're asking to respond. So the Maslach Burnout Inventory has 22 items, 22 questions. The Oldenburg Burnout Inventory has 16 items. The Copenhagen Burnout Inventory has 19 items. I mentioned the Mini-Z at its core has 10 questions that it asks. The Stanford Professional Fulfillment Index has 16 items. There is actually a single item physician work-life study, which is a single item survey. One that's not mentioned up here is the Mayo Wellbeing Index, which has 9 items. So there's the individual burnout burden of taking the survey, and then you're going to want to think again about organizational burden. So the cost, the complexity of interpretation and analysis, the resources needed to implement the survey. I can tell you my impressions was the Maslach Burnout Inventory, which had very rich data, was actually, there was a fair bit of organizational burden to manage the results and interpret the results. So many of you are going to be, and I hope most of you are going to be interested in using survey data to affect change and to test intervention. So you're going to want to think about, is the survey instruments sensitive to change? And look at the timeframes of the questions used in the assessment tool. So for instance, the Stanford Professional Index specifically asks questions about burnout and professional fulfillment in the preceding 2 weeks. So again, if you're going to be considering interventions to potentially improve clinician well-being that are short in time frame, you may want to consider a survey like that. The Maslach Burnout Inventory asks questions in the 22 questions that sort of get at, I never experienced this. I experience this a few times a year, or I experience this every day. So I think it's a instrument to consider if your interventions are going to be multifaceted over a long period of time frame. That may be a more appropriate survey to consider. I mentioned we use the Mini-Z year over year, but the Oldenburg Burnout Inventory, the Copenhagen Burnout Inventory, and the Mini-Z don't actually refer to a time frame. So their sensitivity to measuring change is less well known. And then I mentioned at a little earlier on, who's your audience? What is your scope of activity? Different instruments are sort of catered to different audiences. So the Maslach Burnout Inventory that's directed to medical personnel, that's for all healthcare professionals, as is the Stanford Professional Index, Fulfillment Index. The CBI, OBI, and Mini-Z relate to any occupation, although I'll tell you that I know, and I think Molly was going to enter in the chat maybe links to the Mini-Z and some of the other instruments. The Mini-Z does have surveys that are directed towards practicing physicians. They have a Mini-Z survey that's tailored for medical residents. They have a Mini-Z survey that's directed to administrators or leaders. And I know in the past year, they've created a survey that's directed to our nursing colleagues. So again, just something to consider as you're thinking a little bit about what are the scope of your activities. So we'll start off with the MASLAC burnout inventory. Its original iteration was for all occupations. There is a link to the survey that is called the MBI Human Services Survey for medical personnel. This will likely be the one that you will consider using in the healthcare setting. I mentioned the 3 domains that it looks at. The first domain being emotional exhaustion, the second being depersonalization or cynicism, and then personal accomplishment. And then again, 22 questions in the survey. So examples of questions, an example of a question that is getting at the domain of emotional exhaustion is, I feel emotionally drained from my work. And the response options range from 0 to 6. One of the questions around personal accomplishment, I've accomplished many worthwhile things in this job, and again, 0 to 6. And when you receive the data, you will get scores within each of those domains. So on the right side, I've just put that a score of greater than or equal to 27 is considered significant in terms of being positive for emotional exhaustion. For depersonalization, a score of greater than or equal to 10 is significant for depersonalization. And then a score of less than or equal to 33 is significant in terms of lack of personal efficacy or professional accomplishment. And then, while the focus is burnout, I think there are 5 kind of work experience profiles that you can glean from these survey results. So burnout would be being positive in each of those 3 domains. We're all familiar with overextended clinicians who are not necessarily burnt out. These would be clinicians that score strongly negatively in the emotional exhaustion domain. The ineffective clinician who predominantly scores negative in the professional efficacy domain only. Disengaged would be the cynical clinician, and then the engaged healthcare professional would have strong positive scores in all 3 domains. And again, I think the actual survey has been posted in the chat if you want to look at that. The Stanford Professional Fulfillment Index here. This is really specifically tailored to physicians. It has 16 items, basically 16 questions. 6 of these questions get at professional fulfillment, and then 10 questions are tailored around burnout, either burnout as work exhaustion relates to burnout, or just interpersonal disengagement in the workplace. And again, in the slide and in the chat, you can access the Stanford Professional Fulfillment Index. And as I mentioned earlier, these questions are all really about what's happened in the last 2 weeks. So in terms of action planning, if your action planning is around short-term interventions, this may be an instrument to consider. Example survey questions, a question around interpersonal disengagement. During the past 2 weeks, my job has contributed to me feeling less empathetic with my patients. The scores are from 0 to 4. And when you receive the report online, it'll give you a result as either being favorable or unfavorable in terms of individual or organizational burnout. A survey that I think is gaining traction, although one that we didn't mention earlier in the discussion, is the Professional Quality of Life 5.0 measure, which again, Sarah's posted in the chat. This isn't necessarily directed at just healthcare professionals, but I think any individual or any profession where there's a fair degree of emotional labor with the work, so a teacher, a social worker, certainly a healthcare professional. It has 30 questions, and the survey really gets at compassion, satisfaction, and then obviously compassion fatigue, which is associated with burnout and secondary traumatic stress. Here are some examples of the 30 items. So item number 4, I feel connected to others. The score is 1 to 5, so ranging from never to very often. Item number 26, I feel bogged down by the system. Again, never to very often, 1 to 5. You'll get a score, and the interpretation of the score is if overall the score is less than or equal to 22, that suggests low burnout. Scores of 23 to 41, medium burnout, and then a score of greater than or equal to 42 would be associated with high degrees of burnout. I think these are really some very important additional considerations. And I know I've experienced this at my organization. We all want to get demographic data, clearly. I think that's important. So you're certainly interested in what departments, what service lines are more prone to burnout, what demographics in your organization are more predisposed to burnout. But I can tell you that asking too many demographic questions can undermine not necessarily the confidentiality, but the perception of confidentiality. I remember the first time we issued the mini-Z, and one of my GI colleagues said, you know, there aren't too many gastroenterologists that are between the age of, 50 and 60 that have been at the organization for 2 years. So some folks that are concerned about confidentiality may be concerned when there are a lot of questions that get to demographics. Also questions that get at really sensitive topics like substance use disorder, alcohol use disorder, depression may be a little less well received. I will tell you, though, the downside to completely anonymous or confidential surveys is that you will be limited in intervening directly to individuals that are certainly at risk. And I certainly do agree that partnering with an external vendor or organization will create a perception that there's greater confidentiality rather than developing a home cooked survey and sending that out. Undermining trust, exceedingly important, that only ask questions that you are willing to take on as an organization. There is a fair degree of cynicism, even at my organization, about willingness to direct efforts, to direct resources at interventions. So really, avoid asking questions that you have no willingness to address. And it is the wrong thing to be tempted to diagnose departments or diagnose individuals or groups of individuals as being depressed or just not, meant to be a physician. That these aren't really medical diagnoses. This is an organizational, occupational hazard. While there's the temptation to take out and simplify different questions that may undermine the validity of the survey results, and you certainly want to avoid arbitrarily assigning ranges of burnout. So let's maybe make this bring this to life. So this is, a case study from a former NHSC loan repayment program participant, Scott Richards, who I believe practices on the West Coast, who became interested in measuring well-being at his organization. And he certainly echoed something that we've talked about earlier in this discussion and likened it to ordering tests on patients that will not impact the management plan. So it's similar. Don't order tests or don't order surveys or issue surveys if it's not going to in any way affect how are you going to manage burnout in your organization. And certainly if it just results in ice cream socials or what's perceived to be superficial interventions rather than addressing systems issues, I think it'll just exacerbate the issue. And as he concluded, without perceived effective solutions, clinicians will become more burnt out. And I've been challenged even at times in my organization, does just asking about burnout make the problem worse? I don't think you can outlaw the term burnout, but I know some people believe that we should really emphasize that word less. I don't necessarily agree with that. As mentioned earlier, you're going to want to involve your clinical colleagues from the get-go, and that's what Scott did. And then a big issue, and one that we've tried to tackle at Ochsner, and is actually one of our 5 strategic pillars, is around psychological safety and mental health. Like the military, there's probably no other industry or no other profession where mental health is more stigmatized. So you need to think about ways to destigmatize mental health, which will promote psychological safety. I think some of this is changing how leaders communicate themselves, and I think it helps if our leaders are able to communicate with vulnerability. And then I think it's appropriate to think about interventions outside the traditional EAP box, and think about different ways to meet the mental health needs of your clinicians. Another case study, this is from Mark-Juan Daywalker. He's a current, you may be on the call, a current NHSC scholar. I believe he's based in Richmond, Texas. He advocated for his position at his health system, which is Director of Health and Wellbeing. Certainly, he recognized the importance of qualitative data, and to that end, hosted a number of town halls about burnout, the effect of COVID on clinician burnout. Started to ask for feedback that was anonymous from staff, and then once putting that data together, the feedback results from the town hall meetings, was able to provide some interventions, some self-care resources to those he works with. So again, you're going to want to look at the assessment tools that we've discussed. In this case, Dr. Daywalker, in terms of qualitative data, used the ProQual survey. He used a WHO 5 well-being index, which we didn't mention, just 5 questions that's not around well-being, that's not necessarily focused on healthcare. A 3-question gratitude adjective checklist, asking individuals in the last day, are they grateful? How grateful are they? How thankful are they? How appreciative they are? And was able to assemble data, asking other questions on how individuals cope and asking individuals their perspective on the workplace environment. And then, this is a team sport. The idea that one director of workforce well-being will be able to solve all the workforce professional fulfillment needs is probably not realistic. So this role is usually a role of influence, working with other stakeholders, but also working with other external agencies and partnering with them. Dr. Daywalker was able to partner with the State Primary Care Association in terms of administering the survey, was able to get funding from the local healthcare center controlled network, and then was able to partner with the University of Texas School of Public Health in terms of survey and data interpretation and analysis. I can tell you that we've had some partnerships. One partnership, again, that Ochsner has, I think, really found positive has been with the American Medical Association. They really do a lot of the heavy lifting in terms of the Mini-Z survey implementation, the survey interpretation, and really have been a very helpful resource as I've discussed survey results with their national thought leaders on how to think about shaping strategies and tactics around the survey results. So I'm going to open this up to more of a group discussion. And Molly, you will have to let me know whether these are just sort of chat message responses or whether we're going to have a survey. So first question is, who are going to be the stakeholders that you're going to want to involve at your organization moving forward as you consider an appropriate assessment tool?
And since I think that's one of the questions we already asked, we could probably move on to the next one. Yeah, but someone did, there was one answer that I don't think got mentioned before, but someone mentioned CMO, CEO, clinicians, HR, managers, CFO. So just wanted to make sure.
That's excellent. And I know at Ochsner, we've, my executive dyad is a senior executive in HR. So I know some would think that's controversial in terms of well-being partnering with HR, but at least at our organization, certainly engaging with our CHRO has been very, very helpful. Okay, second question. What level of resources does your organization have for implementing the assessment tool? For example, can you set aside funds, or do funds exist to partner with a consulting firm, an external agency, or does your organization have existing partnerships that can help with little or no cost?
And Nigel, I just wanted to add, for anybody who would like to chime in verbally, there's a icon at the bottom of the screen. Yeah, so if you want to talk, you can raise your hand and we'll send you a request to be unmuted. So please feel free to do that, or post your answers in the chat about funding and partnerships.
I will say on that, I think it's important as you embark down this journey, or some of you may have more mature journeys in place. There has to be a perception by those that you lead that this isn't a flavor of the day. And so, I think, just giving somebody a 0.05 FTE to sort of tackle this at an organizational level will not only be less likely to succeed, but I think the perception will be from your constituents that the organization isn't focused on workforce well-being. Okay, so who then should be on the implementation team in terms of sending out the survey? And anyone can come off mute if you want.
Not seeing anyone who's interested in coming off mute, but please type in the chat who would be on the implementation team at your organization. And don't be shy. We can wait.
I won't cold call anybody. Okay, well, we can come back to that later if you'd like. And again, the fourth question, who within your organization do you need to get leadership or executive buy-in, or even within your managers or frontline clinicians?
I think this might be a good time, Nigel, to say that based on the poll that we asked at the beginning of the webinar, about 36% of folks here are middle management, about 18% are C-suite leadership, 27% HR. We've got a few NHSC participants who are in the field, and some are other NHSC staff. So we do have quite a few folks in leadership positions and HR. So we'd love to hear from you all.
Okay. I think all of the above. I do think my bias is you do have to engage your executive team and probably learn then that how to articulate the value proposition or the business case is going to vary depending on who your audience is. So if your audience is a CFO, how you speak to your CFO in terms of expressing the value proposition may be different than, discussing strategies with your department chair. So I think that's just something to keep in mind. And then lastly, what resources does your organization have to devote to addressing the findings of the survey? And as you're maybe considering that question, I can tell you, at Ochsner, our Office of Professional Wellbeing is now about 8 FTEs, but we learned very early on that, partnering with other business units, partnering with IS, partnering with EPIC, partnering with our Leadership Institute, partnering with our pharmacy team. These are important collaborative endeavors because it's not going to be really an office of 8 FTEs that will solve a workforce well-being crisis for 38,000 employees, and that's how many we have at Ochsner. So. I can go ahead, Molly.
Oh, I was going to say there is one question that we have related to these questions. So how did you use survey results at Ochsner to make organizational changes?
Yeah, so very early on, let's start off with the NASDAQ burnout inventory. We were able to see themes emerge. One theme was giving our clinicians the fundamental tools to do their work. So either staff or stuff. A second theme was around respecting clinicians' time. So interventions to get our clinicians off the computer and give them more face time in front of their patients, in front of their colleagues, or in front of their loved ones. Another theme from the Maslach Burnout Inventory was respectful communication. So we were able early on to look at that data, the results from that data, and sort of consider interventions. I mentioned the respecting time. So how do we start to measure administrative burden? We measure pajama time. Probably many of you do. So how many minutes, how many hours are your clinicians logging into your EHR after work to complete tasks that could have been completed during the day? And then how do you track that, and how do you sort of shape interventions that will reduce pajama time? And so that would be an example of using the survey results to sort of implement change.
Thank you. That's really helpful. I'm not seeing any comments in the chat at the moment. So if you want to move forward, we can, or if you have any other things you'd like to share about your experiences at Ochsner Health, that would be great.
I've been fortunate, I think, that, early on there was a appetite to support this at a C-suite level. I would also, maybe one learning that I've had is to really put strategy ahead of tactics. Physicians in particular are appropriately impatient, so they don't understand why burnout can't be solved in a month. And so it's very easy to come up with, say, 107 great ideas to improve well-being. But I think if those ideas aren't part of a broader strategic plan, they are less likely to succeed. So put strategy ahead of tactics. And the other thing, at least that I've learned, is how incredibly helpful it is to get project management support. These are folks that are basically engineers and are able to bring people together and work with clinicians to, as I mentioned, distill data down to themes, and are able to work with your leadership team to come up with initiatives and execute those initiatives. I think without project management support, sometimes it's very difficult to move from speculation to action. So at least that's been a learning at Ochsner, is to get help from people who are very good at moving projects through to completion, if that makes any sense.
Yeah, that does. And there's a related question that we want to ask in the Q&A. So we may go ahead and move forward to Q&A since we just have about 5 minutes left.
Oh, yeah, sorry.
No, that's okay. And we'll also go ahead and open up the evaluation poll so that folks have time to respond to it before we end. Please let us know how we did today. So you'll see that pop up in Slido. But one of the questions sort of related to, this time frame you were talking about. What was the time frame that you all used to implement your initial burnout survey at Ochsner, and how has that process changed over the years?
Yeah. So we, as I mentioned, we before I took on my role, we used the Maslach Burnout Inventory. The next time we did a survey was in June of 2019, and that's the first time that we used the mini-Z. We worked with AMA to get that out, so we left a survey open for 3 weeks, monitoring the response rate, and then worked with our AMA partners to look at the results. So we have conducted that survey. This year was the 5th consecutive year. Obviously, there's rarely a good time for another survey. I know that our burnout survey can compete with other surveys that the organization believes is important, culture of safety survey. So just be mindful of timing in the surveys. And you'll just also have to recognize that, as it did one year, we sent out a survey in the middle of, we sent out a survey, and then there was the Delta wave and Hurricane Ida, so that other external factors that you won't really be able to influence can also affect survey results. But we've started to see year over year positive change in many of the indices that we track on the mini-Z survey.
I'm so glad you brought up all those additional factors that are going to impact people's, well, one, burnout, but also ability or desire to respond to surveys. That's really helpful, and just making sure everyone is aware of those things.
So I've learned it's very important. Usually the folks from your internal communications team are aware when the other surveys are going out. So you may want to speak with them before you determine a date to send out a survey, because they'll know that in August, this survey is going out, and in November, the employee engagement survey is going out. So I found reaching out to them enormously helpful, at least at Ochsner.
One final question is, so as a transplant surgeon and hepatologist, how did you come to be the Chief Wellness Officer at Ochsner Health?
Well, it started as a personal journey. I don't think I'd heard of the word burnout until 2013, when I went back to my med school reunion in Toronto, and I heard that a close friend had died by suicide. So he was a pretty prominent surgeon. So I became affected for all the reasons that a friend or a physician colleague would be. And then I started, over the subsequent 4 years, thinking about well-being from the perspective of an organizational leader. That it is in fact not a nice thing to have, that it is a leading quality indicator. So if you're interested in patient experience, if you're interested in quality and safety, if you're interested in reducing turnover, if you're interested in financial performance, you have to be interested in well-being. So, and I guess just internally, before I took on my role, I guess I sort of developed the reputation as being a thought leader within the organization. So it's something I was passionate about. Yeah, that's how it happened to me.
Thank you for sharing that journey and your personal experience about your friend, and so sorry about your loss, but really glad that you've been able to sort of take that experience and turn it into something really positive for your organization. That is all the time we have today for Q&A. And I just want to thank you so much again, Nigel, for presenting with us. It was so wonderful. And thank you to everyone who joined us today, and our tech support folks for making sure we didn't have any technological issues. Just a quick reminder that PowerPoint slides and related documents are available to you on the webinar registration page, and are linked in the chat. The next webinar, Fostering Social Support to Improve Clinician Resilience, will be Wednesday, July 12th at 2 p.m. We look forward, or we encourage NHSC participants and leadership staff again from NHSC approved sites to attend, and look out for an email with from us with registration info. And we hope to see you then. Nigel, any parting words before we sign off?
No, I thank you for the opportunity, and good luck to to each one of you as you embark on this journey.
Thank you so much. And you can see the reference slide here in the PowerPoint. Again, that's available. It will be available in a couple of days on the webinar registration page. And yeah, thank you so much to everybody. We're going to go ahead and end the webinar. Have a good afternoon, everyone.
Thanks all.
Thank you.